Good evening, everyone. Welcome to another special edition of the Apex of Training and Development Show. I'm your host, Sharon Casimir Hutch. The Apex of Training and Development Show has partnered with the Antigua Barbuda Cancer Support Community, Mount St. John Medical Center, and Community Charitable Ministries to host a series of cancer awareness programs. Tonight, we continue the discussion with Dr. Nandan Shanbhag, Chief Oncologist at the Mount St. John Medical Center, and cancer survivor Nurse Emelda Benjamin. Just a few protocols for those of you who are joining us via Zoom. Remember to utilize the hand raise icon if you wish to ask a question. And those of you who are tuning in via the Facebook Live, our social media coordinator, Miss Pascale Kentish, will be more than happy to get your questions over to our guests this evening. So we're going to start off this discussion with Dr. Nandan. Dr. Nandan, you are the Chief Oncologist at the Mount St. John Medical Center. Why did you choose to enter into the field of oncology?
Not long ago, Sharian, I was meeting a couple of friends who are into selling jewelry, diamonds and gold and those precious stones. I was interested, so I asked them, how do you manage to sell such expensive stuff? And how do you manage to do it so consistently? So they said, Docs, it is so simple. Whenever a customer walks into one of the showrooms that we have, we look at the eyes of the customer. And when they like something, the pupil, which is the inside of the eye, becomes very big. It dilates. And then we know that this person likes this item, and that's how we know to make the sale. It was July 2019 when I met Sister Benjamin first time. And when we spoke about palliative care and oncology, anytime that you talk about oncology and palliative care, you should look at Sister Benjamin's eyes. They become huge, like a deer caught in a daylight. But the same thing with all of us in oncology. We are passionate about it because each one of us has got our own reasons why we are doing oncology the way that we are doing. For passion that we have. So anytime we discuss anything related to cancer, you can see our pupils dilate.
I love that one, Dr. Nandan. Really great humor to start off the evening. I love it. Nurse Benjamin, you are a cancer survivor, and Dr. Nandan just spoke about palliative care. What is palliative care? Your mic is muted.
Sorry about that. So palliative care is basically the response to physical, psychosocial, and spiritual suffering of a person who is terminally ill. That's just putting it simply. And not only to the patient, but to their family. So palliative care basically is that care that is given to a person who is deemed terminally ill. Medically, we can do nothing else for this patient, but basically they're just waiting for that time. And so that is the care that is rendered to that patient, and not only the patient, you will hear me emphasize their family, because the patient does not go through their suffering alone. The family also is in that suffering. And we as healthcare personnel, we have to remember that we have to care for the family also.
So is the palliative care something like what they offer at hospice in Antigua? Or is it something different? Is it offered at Mount St. John Medical Center?
To a degree, it is offered, but not too fully as what it ought to be. What they offer at the hospice is basically end of life care, hospice care, but palliative care actually starts at diagnosis, and not only when the patient is at basically to the end. And most time what we see here in Antigua is that when the patient is basically to that end point, that is when we say, okay, we send you to the hospice, or we start to speak to the family member about maybe caring for them at home if they want to die at home. But actually, palliative care is much more than that. As Dr. Nandan, the specialist, will give you a little more insight into palliative care.
All right, Dr. Nandan, from a medical practitioner's perspective, can you give us a little bit more insight on palliative care? And why is it so important?
Yes, sure. To start off, I would like to reiterate the fact that palliative care is one of the most complex care in today's era of medicine, practice of medicine. It's no way simple. A lot of doctors, nurses, ourselves have never gone through a training in palliative care. To put simply, what is palliative care? Palliative means to cloak, to kind of hug somebody very closely. And when do you give that kind of a hug? When you know that somebody is in a lot of problems, not just physical, emotional, sometimes financial, and spiritual problem also. Like Sister Benjamin was mentioning aptly, it is so important to recognize when do we start this care. To very simply understand what palliative care, in a very simple definition, is to say to provide good quality of life, to maintain the dignity of life for the patient once the patient has been diagnosed of anything that is life limiting or terminally ill patient, in other words. The problem with palliative care is different continents have got different definitions. Some in Australia call it life limiting illness. In the US, it is called as basically end of life or terminal illness. So because of these changes in definitions, we are unable to kind of come to a conclusion to say this is the standard practice that we'll do for every patient. But nonetheless, it basically means once we recognize that a patient has got a life-limiting illness, for example, where I trained, we took it as 1 year. Let's say the patient comes to our clinic and we recognize that the patient has got a year to live from now. That is where we categorize the patient as probably requiring palliative care. And palliative care starts when the patient is absolutely fit and fine. It is a wrong notion to say that palliative care starts mostly when when we give up and we say we can't do anything else at all. Palliative care offers a lot of things. A lot of things can be done for the patient, for pain, for symptoms that come during that illness when the illness itself cannot be treated. And it is not just the patient, it is treating the family, because remember, the family itself is in a lot of burden. So it is not just the patient, it's the patient and the family.
So who is responsible for palliative care? Will it be the medical practitioners? Will it be the state?
That is such an important question that you raised. A lot of time I put an analogy to the patient to say it is very important to understand one concept. And this is how I was made to understand this concept. Do you watch cricket? I know a lot of people in this part of cricket, right? We all have grown up watching cricket and we love the game. So it is like a cricket team, right? So the captain of the team is always the patient. There might be the best bowler in the team. There might be the best batsman in the team, which is basically a very good doctors, very good nurses. But the captain of that team is always the patient. So everybody has to play according to the captain's requirement. That's when we're going to win the game. So it is not one person's responsibility. It is not one single person that says that I am responsible to take care of this palliative care. It is a responsibility as a whole. It is a multidisciplinary team effort. It is an effort where everybody must get involved equally. All are equal stakeholders. I'm talking about dietitians, nurses, social workers, spiritual healers, spiritual, pastors. All of them are as equal as the treating medical doctor or the primary physician, who play a very important role in providing absolute good quality of care for these patients. So to answer your question very straightforward, it's a team effort. It is all of us together, including this interview today. So you are a part of the team now because you are spreading that message. So you are a very important part of the team now because the responsibility is extended now to you as well to give the right information. So palliative care starts with education, good education. It continues with providing good care in the form of doctors, nurses, all the hospital personnel, not just to the patient, but also to educate the family around the patient. There are a lot of myths that can come up during the terminal illness that the patient can have. So it's very important to kind of support the patient, the family, and also very important is to support each other. Because you don't want, the last thing you want is a burnout among your colleagues, you know. So that is also very vital important. So how do we do it? How do we actually maintain very good care of the patient, the family, as well as the self? So it is very important to keep this in the perspective. So it is a very important team effort that kind of gives good palliative care.
You asked the question, how do you do it? My question is how, because it seems as though there are many parts that are needed to make the whole. So how do you really do it? What's the first course of action towards this moving towards palliative care in Antigua?
The first and the foremost important thing to recognize is that every medical practitioner should be tuned enough to understand the existence of care called palliative care. I believe that everybody should have basic knowledge, maybe a 10-day course or a 1-week course on understanding what palliative care really is. It is not that, once the patient is at a terminal illness, we kind of shun the patient and say nothing else can be done. It is quite the opposite. A lot of things needs to be done when the patient is at a terminal illness. So where do we start? We start with ourselves. Like today is a great start. That's what I would put it. Today, deciding to have this discussion itself tells me that we are interested to start a new course of action in Antigua to see if we can take that course, take that pathway to say we can establish a good palliative care team in Antigua. The second most important step to remember is to recognize that everybody is as important as everybody else in the team. And everybody's focus in the team is towards providing care for the patient. So the only important person in the whole care team is that patient. And we all are geared towards trying to see providing good care for that patient. So that's where I think these are the two basic things we need to start. And education is what we are trying to do right now. Sister Benjamin is at it diligently. So getting that awareness and education is also a big part of trying to establish a good palliative care.
Right. So over to you, Nurse Benjamin. You are about to launch the Antigua Barbuda Cancer Support Community. And I know that you're passionate about palliative care. How do you see your group assisting in the grand scheme of things? Because as Dr. Nandan said, I mean, there are different paths that are needed in order for this to be effective. How important is your group in this entire equation? How do you fit in?
Okay, so my group, as you said, the Antigua and Barbuda Cancer Support Community, and notice it says community because, as was mentioned before, cancer just does not only affect the individual person, the patient, but everybody that surrounds, even the economy, because it is very expensive when you're at that end of life and you have to get round-the-clock care, oxygen, maybe the patient have a dressing, they need a nurse, all these things are very expensive. Plus, it's also important for everyone to understand what a cancer diagnosis can lead to. So in my group now, we'll be educating, not only educating the cancer survivors, but also their caregivers, also the general public. Secondly, is for persons to understand their role. So we want to educate everyone, as we are doing now, and as Dr. Nandan said, it's a great start, to educating everyone on the importance of palliative care, the importance of knowing your rights as a patient in Antigua and Barbuda, knowing what you're supposed to be asking of your caregivers, your doctor. You just don't go to the doctor and sit and take everything that the doctor said. But I love Dr. Nandan, and I love how he speaks to his patients, and he let them know, you're on the ship, you're the captain of the ship, and anything you want, I will have to, because patients have rights. But many times we patients in Antigua, our culture is, we do not think that we can question the doctor. We do not think that we can ask for something else, ask for a second opinion, ask for different treatment. So it's all about educating. It's all about empowering cancer survivors, and not only survivors, but their caregivers, their supporters, and the general public Antigua and Barbuda to understand that not because you're terminally ill means that you have to be in pain all the time. People think that, okay, I must have pain, so I'm not going to ask for any painkiller because I have cancer and doctor said I can't do anything else. I must have pain. But the fact is, you should be dying and be in pain, and there's help for you. So you can ask your doctor, tell your doctor the medication is not working, you know. So you need to be well informed, and that is what we're all about. Educating and supporting, and to make the cancer survivor and their family member realize they're not alone in this. They're not alone, they have support. And so that is why the cancer support community came on stream, because as Dr. Nandan would tell you, they have been giving me a lot of work, and it's just, I'm one person. And I realized, look, there are a lot of people that need this support. There are a lot of people that need peer support in terms of a cancer diagnosis. As I would mention before, I am a breast cancer survivor, and I had breast friends there to support me. But as I'm dealing with these other patients with varying types of cancers, I'm realizing that they need peer support too. And so that is why I had to form this group where we're bringing survivors together with all the varying cancers, cervical cancers, uterine cancers, colon cancers, all the cancers you can think about. Here in Antigua and Barbuda, we're bringing them together so that they can find support among their community. And so that is why Antigua and Barbuda cancer support community is very necessary and very needed here in Antigua and Barbuda.
Fantastic. Apart from the cancer survivors, do you have medical practitioners such as Dr. Nandan and counselors and therapists on your team to support the cancer survivors and their family?
Absolutely. We have, as you said, Dr. Nandan, Dr. Hannibal, they're all a part of the team. And also we have a mental health specialist that work along with us. And although I do not have a social worker per se on the team as yet, there are social workers that are readily available, because we have social worker at Mount St. John's, and most of the patients would come through Mount St. John. So they do have access to a social worker. But what we are lacking, Sherry, and what I want to see at the diagnosis, I want to see that team in place already. As it is now, it's very fragmented. And I want to see it coming together as a cohesive whole. That's my aim. I want to see that when the surgeon says to the patients, because we go to most cancers, is the surgeon or the gynecologist that discovers the cancer, and then the patient is referred to oncology. So I want that at the time when the surgeon gets my report that says I have cancer, I want, when they're talking to me, because that is what I felt I should have had, right? So this is how I work. I didn't get it. I knew it's supposed to be. I want everybody to get it. So I'm going to fight to get it for every person diagnosed with cancer. You can have access to very early, you can have access to a nutritionist. You can have access to a spiritual person, and not going 3 weeks after. I'm saying, okay, I need to talk to a spiritual person, and then we are trying to get a spiritual person to connect you to, and or there's some family issue and we're trying to get an appointment for you with the social worker. I want to see us, and it's going to take a lot of work. I want to see us here in Antigua and Barbuda offering that holistic care to the patient and their family at the point of diagnosis, because that is what true cancer care, palliative care will come in when we realize at what stage the patient is. But very early, we want the patient to know all what is available to them and all what they can have access to in their journey, because it is now a journey of survivorship.
So is it an appeal for persons to volunteer their services, like the social worker, the nutritionist, to come on board to assist the cancer survivors?
Well, might very well have to be. Volunteering.
It sounds like a very costly venture.
No, we know that, right? Because we know that as it is here in our lone hospital, they cannot afford to hire more than one social worker, one nutritionist. And when you think about it, one social worker, one nutritionist to handle all of the terminally ill, because you don't only have cancer patients who are at that stage. You have persons with end-stage renal disease. You have patients with heart disease. You have patients with HIV who are at that stage and requires the same kind of palliative care. So it's very expensive. And so if persons are willing to volunteer their services, it is very welcome. Very welcome.
And how can they get in contact with you in order for them to volunteer their services? Because as we mentioned earlier, the idea is to bring awareness. So now that we are publicizing the need for this, I know that you work along with the community charitable ministries and of course your organization. So could you tell the public how they could lend their support? And I know apart from financial resources, just being there would really go a long way.
Yes, just being there. And as you mentioned, just being there. Let me just share a quick story. I was speaking to a patient recently, and she is about to start chemo. And she was telling me, oh, how much she would like to have someone to sit with her. She was at the oncology and she noticed a patient had somebody there with her while she was going to treatment. And she really desired to have someone to sit with her while she's going to chemo. It is very important. It's a healing process. The person just sits there. They don't have to do anything, but it helps. It helps the patient while they're going to treatment. It helps them psychologically, emotionally, just to have that support system. And everybody do not have family member or somebody to come and sit with them. So if there's anyone out there who have time, maybe you're a retiree, or maybe you work, your work is, your schedule will allow you to be there, to be a support person to someone, to sit with them during chemo, to assist them with picking up their medication or taking them to the lab or taking them for their treatment. We welcome all that. And so you can reach me at 722-1019, or you can contact the Oncology Department at Mount St. John Medical Center, 484-2726. And so I'll repeat those numbers again. For my personal number is 722-1019. And at the Mount St. John Medical Center, you can call the receptionist 484-2700 or 484-2726, and any one of the staff would be happy to guide you and direct you.
And what about the contact information for community charitable?
So for community charitable ministries, I don't have the number on my hand, but I am I am one of the executive member of Community Charitable Ministry. So if you want to support Community Charitable Ministry in whichever way, because we provide counseling for young people, young adults. We also provide food packages. We also provide medical assistance for persons in need, and we want people to come on board too to assist us. So if you want to be a part of Community Charitable Ministry or just to learn more about us, you can also call my number and you will get the information you desire.
Thank you so much, Nurse Benjamin. Very insightful information there. Dr. Nandan, Nurse Benjamin spoke about patients having a right. They need to know their rights. And she mentioned, as a patient, you have a right to a second opinion. What are some of the other rights patients have that they need to know about? Dr. Nandan, could you please unmute your mic?
Yes. Can you hear me now? I'm sorry about that. So
Yes.
what I was saying is that I would like to touch upon also the importance of a support care group, and it will also touch upon what are the rights of the patient. Now, to establish a good comprehensive cancer program in any country, there are 7 important things that we need to do. 7 is a very magical number. 7 is such an important number. 7 days, 7 colors of the rainbow. So if you look at it, 7 is such a significant number. So the first important thing is to know if we can have a good screening program. So it's a patient's right to see if they can be access to get that screening to see if the cancer can be diagnosed early. That is the second part of it. First is to have a good screening. Second is to see if the patients can be diagnosed early. That is the whole idea of screening. And once you diagnose the patient has the right to get a good treatment for the disease that has been diagnosed. After having a good diagnosis and treatment, patients have the right for a good follow-up. So the patient will have to be followed up in the oncology department so that we can rule out recurrences. We can see that the patient has been managed properly. In case the patient is having a stage 4 or a terminal illness, the patient has rights to palliative care. And the last part of this right is the patient's survivorship program. That means the patient needs to have a long-term survivorship plan on how to kind of manage the side effect of treatment or also the side effects of the disease itself. Excuse me. In each of these 7 categories that I spoke about, support group plays a very important and a vital role. Support group forms the main structure, the backbone of all these 7 things that I spoke about. And these 7 things are the basic right of a cancer patient. So that answers your question to say what would be the rights of the patient. So right to get screened, right to get managed, right to make sure that there's an early diagnosis, right for proper medication, right to make sure there's a follow-up, right for good palliative care and supportive care as well, and right for a good survivorship program as well.
But what if the patient doesn't know that there is a palliative support team in place? Is the oncologist or the nurse obligated to inform the patient of those rights? Is it the first discussion they have when they transfer to the oncology department?
Yes. A lot of things I must say has changed in the oncology department thanks to the support of Sister Benjamin. Earlier, we did not have anybody who could sit and counsel with the patient and talk to them and provide support in a way which could be a continuous support, even if the patient is going to the hospice and then going home from there. So what we do nowadays is with the patient having a terminal illness, we definitely have Benjamin discuss the case with Sister Benjamin, and Sister Benjamin sits with the patient. And as a team, we all decide together to see what are the challenges that the patient and the family is facing. The most important thing that we as a department, as a team, is to give as much as time possible to the patients. We have decided that we are going to listen to them, even if it takes hours together to sit with them and discuss with them. Sometimes, in my OPD, you can have patients sitting there for about a couple of hours, 2 hours or 2.5 hours even, asking questions and discussing things, while the other patients are waiting outside, but we make sure that everybody gets that time. So that has been done. So that step has been done in the department already. So we do kind of discuss with every patient when they come in, what are the options that they have. informed consent is a part of the everything that we do. What is an informed consent? Informed means we give all the knowledge and education to the patient as much as possible. Everything that is available in Antigua, of course, things that are not available here, it is unfortunate that we cannot provide to the patient. But whatever is available in Antigua, we give that information to the patient. And then it is a consented process. So there is nothing that tells the patient that she or he has to do what I tell them or what Sister Benjamin tells them or what the other doctors in the department tell them. It's a choice. So they give consent willingly to say, I want to take this pathway. And we support them. No matter what decision they take, we always tell them that our doors are always open. There are a couple of patients who refuse treatment and they say, we want to go the other way, we want to do something else, we want to try out something else. But we always tell our patients, no matter what, when you come back, our doors are open. And we will still support you for whatever you need. We will still sit with you, we'll still discuss with you, we'll still see what best can be done for your condition.
All right, for those of you who are tuned in via the Facebook Live, remember you can leave your questions in our comment section. Miss Pascale Kentish and Ajane Seeley will be more than happy to share your questions and comments with our guests this evening. Dr. Nandan, I've always wondered, how do you determine how long a patient has to live as a medical practitioner?
Oh my God, you asked me the most difficult question. The only person or the only entity that can determine how long anybody will live is God. And I don't intend to play God any time at all.
Yeah, but then sometimes people, you hear you have 6 months to live, 3 months to live.
Yeah.
How do you come to that conclusion?
Yeah. These are all prognostic scores, which we usually refrain from telling the patient. You know, it's not like straightforward. We sit in the department and say, oh, you got 3 months to live, or you got 6 months to live. That is not the way it should be done. There are some times when the patient asks us, Doc, what do you think is my time? Because I need to kind of get my affairs in place. So how much time do you have with your experience, with your clinical experience? So we have certain prognostic models. That's why we stage every cancer, because depending on the stage, I will know exactly what is the survival of the patient. When I say exactly, this is statistics. Let me give you an example. Let's say I tell the patient that you've got 70% chance that you'll live for a year. What does it mean? It basically means out of 100 patients who came into the clinic with the same stage, what the patient has got, 70 people have lived for 1 year. 30 people have not lived for that 1 year, you know, when we see the patient next year. Now, if this particular patient lives for that 1 year or not, I will not know until that 1 year passes away, you know. But it is statistics. So we tell them, okay, you have got a 70% chance that you will live for a year. So when we say that this is a prognostic indicator, it is not a definite, it is not written on, it is not written in rock. It's not something that we stick by and say, oh, this is what I'll follow. Doctor said 1 year and I'm going to live for 1 year. It is not so. It is just an indicator for us to make sure that we are doing the correct line of treatment. You cannot be very aggressive with a patient whom I know that is a stage 4 disease, metastatic disease. You just cannot simply be very aggressive, because that is going to be financial burden, that is going to be an economical burden, that is going to be a social burden. And then before we know, the patient has spent most of the time in the hospital trying to go through all the aggressive treatment for that 6 months or 7 months that they had, rather than trying to enjoy their life, the quality of life. So these are indicators for us to just kind of see if we are going in that direction. I've had some hard lessons in the sense, Go ahead, sorry.
Go ahead, you go ahead.
I've had some hard lessons when I say this, because sometimes when I think, when we had this discussions with patients and patients says, I had patients telling me, doc, another doctor, oncologist has told me I lived for 3 months, and patient is living for 2 years now with treatment. So it is not that, it is written in stone. It is just an indicator.
Right. How important is it for the nurses, the orderlies, and the doctors to have emotional intelligence? Because I don't think anyone wants to know that they are at stage 4 cancer and they're terminally ill. But from your perspective, how important is it to be able to connect with the patients at that level?
I was very lucky to be trained by chiefs and mentors who were oncologists, who were world-renowned oncologists. My chief always told me one important thing. He said he would anytime prefer an oncologist who has got very high emotional intelligence versus an oncologist who is very good in his subject. Because according to him, which is absolutely right, you can teach somebody medicine. You can actually teach them the science of medicine. You can teach somebody, if somebody reads a book, what is the difference between somebody who's not a doctor and a person like me who's a doctor? It's just that I've read some books more than that person who's not read those books. That's all. But medicine is an art. Now that art is the most important thing because that art is not given in any books. It is not mentioned. It cannot be learned with literature. It has to come from practice. It has to come from clinic. It has to come from your heart. So it is so important to be emotionally intelligent. It is so important for everybody, including the nurses, the doctors, because we are dealing with human beings, right? We are not dealing with objects. We are not dealing with computers. We are dealing with somebody who has got life, who is an emotional person, who's got a physical being, who's got a spiritual being, who's a social being. So it's so important that we are not just physically intelligent, but we are emotionally, socially, and spiritually intelligent as well. So the spiritual quotient needs to be developed for us. We have to have a high emotional quotient and a social quotient also. So it is important for us to develop all that in us as well as we talk to the patients. How spiritually intelligent am I is so important. How emotionally intelligent am I is very important. I just want to add here because people think that sympathy is what the patients want. It is not sympathy. It is not even empathy. There is a difference between the two. Sympathy is when you start to feel like, if somebody is crying, you sit next to that person and you start crying. So now instead of one person crying, we have two people crying, right? So it doesn't solve the problem. Trying to understand what the other person is going through. What we need is compassion. It's not even empathy. We need to go one level ahead. And we need to understand that compassion we require. What is compassion? Compassion is not just empathizing with your patient, but taking action, taking a solid action to say, okay, I understand this patient has got a problem. What am I doing to address that issue? There are papers written, there are papers and papers written, people who actually take compassionate practice in oncology can avoid burnout very easily. People who just empathize or people who just sympathize with patients are known to kind of burn out very quickly because they don't know how to address the issue. I see a lot of doctors who basically are empathetic, but unfortunately they're not compassionate because there's no action that they realize should be taken to address that issue. So that should be the goal. So to answer your question, it's very important to be compassionate. And I think one of the mottos the nurses have developed for our department is that. I think Sister Benjamin, would you like to give us that motto on the T-shirt that we have? I think I have it right on my T-shirt here. Can you read it? It says fearless commitment and endless compassion.
Fearless commitment and endless compassion. I love that. A really, really good one. Before I go over to Nurse Benjamin, Dr. Nandan, do you not think that the doctors and nurses, they are overburdened with all these different patients coming to them? Don't you think they need some sort of mental help as well in order for them to be able to be emotionally intelligent or connect with the patients emotionally? Don't you think something has to be deposited into them as well in order for them to be the best them to the patient, well, the best nurse or doctor to the patient? Because I can imagine it being overwhelming if you have so many different cancer patients or terminally ill people coming in front of you every day and you can't solve their problem.
See, Sharian, that's not, I mean, it's true for everybody, right? It's true as a human being because we can get overburdened in today's era with a lot of things. There is a tendency that we can get cluttered in our mind if we do not know how to handle things. So we need to have that education, that support. I mean, we need support group, right? So as doctors itself, we need support group to make sure that we do not go into a burnout. We each need to find out what is that support group that we can borrow the energy from to make sure I can go back the next day in the morning 7:30 to the hospital and with same energy speak to the patient with the same kind of love care that I can actually give to that patient. So you're absolutely right, but it is an individual, I would say it is like individual existence that we need to find out what is it that gives me that source of energy to go on day in and day out. I might have something, you might have something else, Sister Benjamin might have something else. So we each need to find out what is it that kind of gives us that happiness other than work as well, to go back to work with a lot of energy and the same kind of commitment that we can give to patients. So I completely agree with you that we need all the doctors and the nurses as well. We need to kind of get that educational, emotional, educational kind of a resource from time to time to keep ourselves not just up to date in medicine, but up to date as well when we kind of treat our patients as well.
Right. For those of you who are tuned in via our Facebook Live, remember to share the live, call a friend, call a family member. We are discussing palliative care, which is such an important topic. And for those of you who are interested in supporting the Antigua Barbuda cancer support community, as they said, it's a community. So we need as many persons to come on board to support the nutritionists, more doctors, people just being there to assist the cancer survivors as they go through their situation. Contact Nurse Benjamin or the oncology department at the Mount St. John Medical Center, and she'll be more than happy to provide the much needed insight for you to assist in whatever way you can. Again, if you have any questions for our guests, you can leave your questions or comments in the Facebook comment section, and Ajane Seeley and Pascale Kentish will be more than happy to share your comments or questions with our very special guests. Nurse Benjamin, you spoke about the breast cancer being, well, as a cancer survivor, you spoke about breast friends supporting you. What difference did breast friends make in your life, as well as persons close to you, to help you with go through the process? Like, as you continue on your journey, how different, well, what about the support that they offered you? What made it different? What caused it to help you to overcome the challenges somebody without support would face?
Okay, so as I said, breast cancer survivor, and very shortly after I was going through treatment, I was introduced to Breast Friends. And what it does for you is I could ask questions about what to expect of the treatment. I mean, I had support in terms of persons giving me tips and ideas as to how to cope with the side effects of the treatment. If I wanted to talk, I had somebody I could call to talk and share, share my concerns with them. It's just like having that shoulder to lean on, and that's what Breast Friends, Women in Touch Cancer Support Group is all about. Just women who have gone through the same road before me. I remember calling one friend because she had started treatment before me, and I would ask her what to expect. I'd ask her, like, when did your hair fall out? And then she said, after my second treatment, her hair started falling out. So, it's just to know that you can call somebody to talk to to share your concerns with, and they are always there to listen. They're always there to support you so that you don't feel like if you're alone. And in my group now, we have adopted the motto, no one fights alone, because really and truly you feel like, I don't know about for other survivors, but I know for me, when I would have encountered another person with a cancer diagnosis, I just feel like we have some sort of connection. I just feel like we are family. And I just want to go to the ends to help them if I have to help them. So that support, it makes the coping with the treatment easier. Just knowing that you have somebody you can lean on when you're not feeling yourself, somebody just there to give you that pep talk and to just give you that support, that emotional support that you need.
And again, could you please share your contact information with the public?
Yes, so anyone,
yeah, go ahead.
Anyone who would like to learn more about the Antigua and Barbuda cancer support community, or if they just want to talk about palliative care, maybe they have someone who is terminally ill. It doesn't have to be cancer. It could be any other kind of end of life situation, terminally ill situation, and they are having concerns. They need someone to talk to. They need some assistance. They can reach out to me at 722-1019. 722-1019, or they can call Mount St. John and ask to speak to the oncology department.
The breast friends, they have grown over the years. Where do you see the Antigua Barbuda cancer support community in the next 5 years?
Oh, in the next 5 years, as Dr. Nandan so nicely put in his little congratulating note to me, our group is the first of its kind in the Eastern Caribbean, Sherian. Yes.
Oh, wow.
In 5 years, we will be having chapters all over the Eastern Caribbean. This first in Antigua and Barbuda is going to be across the Caribbean in 5 years.
Wow. What about Cancer Survivors Day? Is it the first time this is being celebrated in the Caribbean?
I do not have any information. Maybe somebody can help me, but we did our little research, and as far as we know, we have never celebrated Cancer Survivors Day in Antigua or in any of the islands in the Eastern Caribbean. It has been celebrated it started in the United States. I think this is their 34th year celebrating, but it's the first in Antigua as far as I know. And as I would say to people in 2019, you're a cancer survivor now, so everything with cancer jumps out at you when you're on the internet. Everything you want to learn more, you're searching, you're Googling, and I came across this Cancer Survivors Day and what they were doing in the States to celebrate cancer survivors. And what I noticed though, in the States, because the United States is big and you have various cancer centers, so the cancer centers, they would put on programs on that day to celebrate the survivors, their patients, and they would have varying functions to celebrate life. And it's not only about celebrating life, but very importantly, it's about bringing awareness to what a survivor's life is like, what they're going through. It's also to advocate on behalf of survivors. It's also to push for legislations to be in place so that cancer survivors can have the proper care, the quality of care that they so deserve. So we say we're going to be celebrating life, but I want us, I know this is our first, and we're not really where we want to be, but by next year, we want people to know that it's not just celebrating life, but it is about awareness. It is about advocating for that quality of care, for legislation to be in place so that cancer survivors can receive that quality. We're talking about quality. When we talk about palliative care, we're talking about that quality of care that the person deserves at end of life. Why I do what I do at Mount St. John? Everybody needs to die. Everybody should die in dignity. I don't care where you come from. I don't care if you're one of those men from down by Kennedy. You deserve to die in dignity. So I would go to the ends to make sure that the patients I come in contact with, they get the best of care, the best quality of care.
All right, those of you who are locked in via our Facebook Live, remember to share the live and remember to leave your comments and your questions in our comment section. Miss Ajane Seeley and Pascale Kentish will be more than happy to share your questions with our very special guest this evening. Tonight, we're joined by Dr. Nandan Shanbhag, Chief Oncologist at the Mount St. John Medical Center, and Nurse Emelda Benjamin, oncologist nurse, nurse in the oncology unit, and a cancer survivor. And I'm so happy to have them in my company. This is a very interesting discussion on palliative care. Dr. Nandan, we have spoken extensively about palliative care. I would like to find out from you, at what age should cancer awareness begin? Should it begin in this primary or secondary schools?
That is such an important question. It's a very, very important question. So Sharian, to give you a perspective about what is happening in cancer. See, in 2018, there were about 18.1 million cases of cancer that were reported. 9.1 million deaths were reported. By 2025, we are expecting about 24.1 million cases of cancer as incidents. And we're expecting 13.1 million deaths. By 2030, WHO has said that cancer is going to be the #1 killer, even overtaking heart disease. We're going to see about 29.2 million cases of cancer by 2030 and about 16.3 million deaths. These are the numbers from World Health Organization. So if you go to the website, you'll be able to get those numbers. Now, 60% of these incidents of cancers happens in low and middle income countries. 70% of these deaths happen in low and middle income countries. So we require awareness, that education that we are talking about in low and middle income countries now. When should it begin? When should the awareness begin? I would say the awareness should begin yesterday. There's no better time to say if we can start to talk and start to make the educational sessions much more, commoner, much more accessible. To put in perspective, just to give you a small story, when Bruce Lee was asked, who is the most fierce opponent that you are scared of? He said, I'm not worried, or I'm not scared of that opponent who knows how to kick in 1,000 different ways. I'm only scared of that person who has practiced that 1,000 times. That is my fiercest opponent. So we need to make an impression in cancer to make sure that we give these educational sessions 1,000 times. Can be made. These educational sessions that we are having should be made more often, not just during an October month or a special awareness month wherein we do this, all get excited for a month, we do the educational session, then we forget about it. It has to be a regular affair. It has to be maybe every month, every 15 days, at every single opportunity that we can get. So these awareness programs have to be done. Now, to answer your question very specifically also, that you wanted to know, should it be, at what age should the awareness begin? Well, if you look at it, we have to have this awareness of cancer screening and all that to the general public, depending on what cancers we are trying to focus on. Like if it's breast cancer, if it is colorectal cancer, if it is prostate cancer, because our resources are limited. All right, in our countries, the resources are limited. We are not blessed with unlimited resources like probably developed nations. So we have to do very focused awareness campaigns. We have to make sure that the resources that we have are utilized economically, properly, and in a targeted way. That is the way to go. So we'll have to target. We have to choose our target population. We have to understand whom are we targeting this educational resource towards. Whom are we targeting about breast cancer and breast cancer awareness towards? I think that's where it should start. And once we kind of get that, because we did something last year, I was also mentioning in a talk that I gave yesterday. It was a wonderful interaction that I had yesterday as well in a church. We did a small thing study last year, which was presented at the National Cancer Comprehensive Network, which is a large symposium in the US. And it was the first time a paper from Antigua was published in that symposium. And we looked at breast cancers coming in from different parishes in Antigua and Barbuda. And we did that because we wanted to understand where the maximum incidence of breast cancer is coming in from. So that probably if there is a time to do these educational sessions or educational awareness, we can go targeted to those areas and give them targeted educational sessions to say, how do we identify breast cancer? Now in Antigua and Barbuda, the average size of a breast lump that comes in our clinic is about 4.5 to 5.3 centimeters. All right. The average stage that we're looking at then is stage 2 and above. So we don't see many stage 2 and below cases. So once I know this information, I can actually focus my attention, focus my all energy. When I say I mean we as collectively as us, to say which are those parishes that we can go to and talk to the nurses, talk to the doctors and say, listen, we are getting breast cancer patients with 5-centimeter lump in the breast. What can we do to see if you can send us earlier? Maybe with a 1-centimeter or 2-centimeter lump in the breast. So the moment the patient comes to you, why don't you just send it to the surgeon to see if something can be done very quickly? These are the risk factors that we should be thinking about. So the awareness and the education has to be very targeted. It has to be very, very targeted in that way.
Do we know what are the causes of the breast cancer? And can somebody have cancer without even knowing? Can somebody die with cancer? Can that be determined? Like you die, but you didn't know you had cancer?
Yes. See, basically, we don't know the causes of breast cancer, but we know the risk of breast cancer. Most common as risk factors would be if you have somebody, a relative, who is having a breast cancer, like maybe the mother or the sister. We call them as the first degree relatives. Okay. So these are, we have risk factors of breast cancer. So if we have late, menarche, early menopause, or a late menopause, so that the hormonal, the exposure that you have. I'm sorry, when I said early menarche, that you have an early initiation of your menstrual cycle, and a late menopause. That means the hormonal exposure that you have is longer. So they are at risk of developing breast cancer. Then you can also have somebody who basically has given late childbirth because the breastfeeding has not been done. So they are at risk of developing breast cancer. If you have a benign lump in the breast, like let's say fibroadenoma or lipoma, or any other breast lumps which are not cancerous, they have a chance of trying to become cancerous in the lifetime. In 10 years or 15 or 20 years time, it's about 3.5%. For example, for fibroadenomas, which is a benign lump in the breast, which is not cancerous, it has a chance of becoming a cancerous lesion in it's about 3.5% in about 15 years. So these are the risk factors that we're talking about for breast cancers. Can somebody die without knowing that they have got cancer? There can be a situation where a person dies, has not taken any medical support. Let me tell you one thing. Most of the patients who come to us, for example, prostate cancers, come at stage 4. What it means is basically the cancer has spread to the bone already. The cancer has been there in the prostate for a long time. And then the patient has been living with it for a long time without going to without doctor's help. And then the patient comes and they don't have much time. They don't have much time to live at all. Most of the breast cancers that come to us are also our large breast masses that come to us. So that's where the patient has passed away because of the cancer itself, but because they have not taken any support or any kind of consultation from the doctor, they have not realized what is the cause of their death. We see advanced cases of cancers.
Okay.
We see advanced cases of cancer.
Oh, sorry.
Sorry about that.
Can breast cancer be completely cured if it's caught at an early stage?
The motto for oncologists ever since we have had the technology and the novel methods of treatment is that if the cancer is detected early, there's every chance that we can go for a cure for the cancer. Okay. Now, the problem is that cancer, the challenge with cancers is that it can always come back even 18 years later, 20 years later, 25 years later. So we are a little hesitant to use that word to say cure. So doctors use the word called remission. We see that when the cancer cannot be seen in the body, we use a term called the patient is in remission. That means there is no disease in the body anymore. But I will be bold enough to say, if a patient can be diagnosed early, we definitely can think about a cure, because that is the only way to motivate the general public to go for a screening program. That is the motivation to tell the public that this is why you do the screening program, because if you can catch the cancer early, I can definitely think about a cure for you. So definitely, if the cancers are detected early, which is a part of why we are trying to educate the people to go see your doctor at an early stage, we can definitely have better cure rates. We can have better survivors. We can have longer follow-ups for these patients as well.
But what if there are persons that just can't afford the screening? Is there, Nurse Benjamin, probably you can come in here. Does your support group and community charitable ministry assist persons that just cannot afford to do a pap smear or a screening, a mammogram, or even a prostate, to check their prostate? Because I would like to think that there might be people in society that just might not be able to afford regular screenings. Some of them may not even have insurance. What kind of support is your group offering those people?
Okay, so my group, as you would know, the Antibiotic Cancer Support community, we are very new, not much finance, but we know how to network. So, and then there's community charitable ministry. We have been around for a while, but we are not that big with that big of an account. But as I can tell you, as I said, we know how to network. So there is help available. We have Breast Friends. We have the Prostate Association, Do Blue. I know Dr. Thwaites, every year he puts on free screening for prostate cancer. So men, they need to avail themselves to these free screening. They are varying charitable organizations across Antigua and Barbuda that will offer assistance. So what people need to do is people need to come out and contact these organizations and ask for help. It doesn't make sense saying, I don't have the money to go to the doctor. I can't wait for the long appointment given to me at Mount St. John to get a ultrasound or some sort of screening done. So it's important for you to ask questions, reach out, and ask for help and get your screening done early, because as Dr. Nandan would have explained, it is very important for us to get the cancer at an early stage. You stand a better chance if it is caught at an early stage. So don't let the fact that you do not have finance keep you back from getting your screening done. And yes, Sherry, and we do assist persons with getting their pap smear done if they cannot get it done at one of the clinics and they need to go to a gynecologist to have it done. There is assistance available. All they have to do is to reach out.
All right, and again, your contact information is
722-1019. 722-1019.
And they can also call the
And they can
oncology
call the
unit.
oncology unit at Mount St. John's Medical Center.
Thank you
And
so much.
Let me share here how important what we are doing here, because the very first time I went on Observer Radio, Dave Lester Payne, I received a call the next day from a lady who was diagnosed with cancer a year ago. And she did not seek medical help. And I mean, I can't remember the last time I heard somebody was so excited. This lady was so excited that she heard me on the radio, and she was just anxious for a contact number to be given. And once she got that, my contact number, she called me first thing next morning. And right now we're working with her to get her treatment started. So this is how important it is for people, for us to be here and informing the general public, and for people to make use of the information we're giving out. Call the number, don't be afraid to call. Your information is confidential and you will get the assistance that you need.
Thank you so much. Dr. Nandan, we're about to wind down this evening's session. Again, those of you who are locked in via our Facebook Live, you could leave a comment or ask your questions through our comment sections, and Ajane Seeley and Pascale Kentish will be more than happy to share your questions with our very special guest. We have Dr. Nandan Shanbhag in the house, Chief Oncologist at the Mount St. John Medical Center, and Nurse Emelda Benjamin, a nurse within the Oncology Unit and cancer survivor, sharing her experience and a little insight on her organization, the Antigua Barbuda Cancer Support Community. And they are, of course, working in collaboration with the community charitable ministries. Dr. Nandan, before we wind down, persons that are terminal, we spoke about palliative care, but what about persons that are experiencing the side effects of the chemotherapy? How do you assist them with that?
Yes. Sharian, I must tell you that we have come a long, long way now as far as oncology is concerned. So it's no longer that, the patients will keep vomiting or patients will have any of those side effects that we talk about. There is going to be the usual ones like loss of hair. When I say usual ones, it might be easy for me to say it's usual ones, but for a patient, trust me, losing hair is not an easy experience. I've had patients who come up to me and say, Doc, this is the most dreaded experience for me. It is more dreaded for them than being diagnosed of cancer, because it is an image. There's a self-image. We all have our own social or self-image that we don't want to be affected with. So it's not easy to see yourself with no hair in front of the mirror. I always tell my patients that, please look at the future, because once you finish your chemotherapy, you will grow beautiful hair, much beautiful hair than what you had when you started the treatment. I tell them that, you'll have hair like a teenager, and people will ask you, like, what did you do to grow such beautiful hair back again? So we have to look at those future rewards and then go through the treatment to make sure that the treatment is done in an accurate way, in a precise way. We do give all the pre-medications possible to make sure that the side effects of chemotherapy are kept to a minimum. In case if the side effects do occur, which go beyond the minimum that we can control with those pre-medications or with those injections, we tell the patients to come back to us immediately so that we can address those side effects very quickly, so they don't become life-threatening. So side effects like nausea, vomiting, hair loss, or loss of appetite, weight loss, all these are taken care of by giving certain injections to make sure that the patient does not go with these side effects to a larger extent. There are newer things that have come in, like to prevent hair loss. There is this ice cap that the patients can use. So my previous hospital, we used to use those ice caps when patients sit with the ice caps through the chemotherapy and then complete their treatment and not have. But I did not see that much of an improvement, that patients did not lose hair at all. They still lost hair. So I felt that was not something great for the patients to go through for those 30 minutes. So I would say that the chemotherapy side effects are to a minimum as compared to the yesteryears, where we did not have enough those medications to counteract the side effects of chemotherapy. I just see patients actually, when I go mall, who have done chemotherapy in the morning or yesterday, and I see them in the mall screaming my name, "Hi, Dr. Nandan," and I'm like, "What? You should be at home, relax. You should be at home. You should not be coming out and doing." No, I feel absolutely fit and fine. I feel absolutely nothing at all. I feel great. So there are some patients who actually have more side effects compared to people who do not get side effects. Our department is always open to say, please come back to us, speak to the nurses, speak to the doctors, so that we recognize these side effects very quickly and make sure we address these side effects as early as possible.
Does your immune system have to do with how well your body receives the chemotherapy? For example, if you have a stronger immune system than someone else, would the side effects, would you have less side effects? What determines how much side effects you end up with?
I see, Sharian, you have read a medical textbook today before starting this session, because you are right.
I didn't.
Right.
I didn't. I didn't even get a chance to read today.
You are speaking the oncologist's language. Immune system has got everything to do with it. You know, you're absolutely right. Immune system has got every single thing, right from developing the cancer to knowing how to get the treatment, because our immune system is the key. So yes, if your immune system is strong, the side effects are much lower compared to somebody whose immune system is weak to start with. So with such people also, we are very cautious when we start chemotherapy or systemic therapy or any kind of treatment. So we are worried if the immune system is not good or up to the mark, we might actually start treatment at a lower dose or at a level which is comfortable for that person. So definitely you're right that immune system is the key for making sure that the treatment is successful and the patient is able to take the treatment as well.
Also, what about how do you get patients that would have learned of their diagnosis, their cancer diagnosis, to buy into the chemotherapy versus the naturalists, what the naturalists have to offer, like natural medicines and stuff like that?
I think that this question quite comes up a lot of times whenever I give a talk or whenever there's a discussion about, what about the naturalist and what about your allopathic medicine that we practice. I always tell my patients that I'm not an expert, or I do not have a certificate in naturopathy. So I'm not in a position to say that is wrong or that should not be done, or don't do this or don't do that. But I can tell you that in allopathy, I'm certified in allopathy. I'm certified in oncology. I can tell you that my science is not a perfect science, but it's a science. All right. It's not a perfect science. It's definitely not. Let's not get things mixed up and so, this is the perfect science, the best thing that we can do for cancer. It is not. It is an imperfect science, but it is a science. When I say that, I am giving the opportunity to improve. I am keeping the doors open to say, listen, my mind is open. I am ready. I am willing to improve for my patient's sake. If this drug does not work today, I am looking for another drug that can work better. So that is where the power of allopathy lies in. That is the power of the science that lies in, because we know it's an imperfect science. We know that everybody who practices this needs to improve it, right? So if I say, there's nothing needs to be done, I'm perfect, I'm not going to improve myself, that can't be science, right? Science basically means that it has got its imperfections, it has to be improved, it has to go to the next level, it has to be researched, it has to be improved upon from what they have been doing for all these years. And that is the strength of allopathy. See, when a patient walks to our clinic, for example, if there's a breast cancer patient, when I talk to her about chemotherapy, I exactly know what are the side effects that are going to happen about chemotherapy. I know that it is a statistics again. I know that when I give this kind of chemotherapy, there will be hair loss, there will be other side effects that might happen in this patient. But I also know what is the percentage that this chemotherapy might work for this patient for this disease. Unfortunately, with the natural remedies or the naturopaths, we do not have that kind of a scientific evidence or the base evidence that I can construct my arguments upon. That is where the lacking is. That is where we find that lacking comes from. So I think that the naturopath or the herbalist should think in a way that, okay, let's kind of start building an evidence-based system wherein we have evidence to say, I'm going to practice this and I'm going to do this, and this is the evidence that I've got. Not saying that it should be 100% right all the time. You can't, right? There are chemotherapy drugs. In fact, if I tell you, most of the chemotherapy drugs have been discovered out of accident. Most of the drugs that we practice have come out of an accident. None of these drugs have come out of saying, oh my God, I know the best, I've discovered this chemotherapy. Most of the drugs have come out because of an accident. Radiation today, the radiation that we practice today was because of an accident. Because of an accident. It was not because of some scientific genius that we said, oh, we know we found out radiation and so I'm fine. The first X-ray that was taken of a wife, of the scientist's wife. He wanted to see what happens when you put his wife's hand under this peculiar looking, which he couldn't see through eyes, radiations that he couldn't see. And the ring that you see even today that was taken shows the engagement ring of the scientist's wife, Sir Ronjan's wife. So most of these things that have come in our science have come out of accidents. And we acknowledge that. And that's the beauty of my science. That is the beauty of my oncological science, that I acknowledge completely that I might be wrong. I am going to look for, if something is wrong, I'm going to improve myself. How do I improve myself? I'll keep going towards what I can do to avoid these errors in the future. So we do make mistakes, but we correct those mistakes, and that is the strength of my science.
You have evidence to back up your science. You have that data, you could empirical data to refer back to and say, hey, this is based on evidence, as opposed to the naturalists or the holistic doctors. Well, that was quite insightful, the importance to record data. I think that is some really, really good advice there, because you can't really just speak out of a vacuum and say, okay, this will work. But what empirical data do you have to prove that this would work? So quite insightful.
And not just, I'm sorry, and not just that, we critique that data. That is a strength. Not just having the data, it's just not saying I have the data, so this is right. The ability to critique it. So the ability to say that I'm going to critique this data, everybody has got the right to say, I'm going to critique it. If Dr. Nandan writes a paper tomorrow, I'm going to sit and read that paper with a lens to see what is right, what is wrong, and how can I better it. So critique in a positive way. How can I better what Dr. Nandan has done? How can I accommodate it in my medical picture? And that's the strength of it, because we can critique it as well.
So, critiquing it, wouldn't you have to have like evidence that what Dr. Nandan said is incorrect? Wouldn't it be based on some sort of scientific data? You doing some sort of test on a patient in order to determine whether or not what he's saying makes sense?
Yes. See, it all depends on the philosophy back again. See, it need not be that, because I'm wrong, you're going to do another experiment. It just might be that Sharia knows another way to do something better, So it just may be that. It might be that I'm absolutely right what I'm doing, but you might have a better way. You might have a better drug that actually makes patients feel at ease, where the vomiting can be controlled much faster and better. It doesn't mean that my drug was wrong, what I was doing was wrong. It only means you know a better way, a smarter way for this patient. So the moment you come and tell me, Dr. Nandan, see, I found something that, this drug works better for this patient. That's the beauty of medical science. I take that, I acknowledge that, and I say, I'm going to follow from henceforth Sharian's method, because it's simpler, it's easier for the patient. My method was right, but I'm going to follow her method because it's much more easier, much more simpler. And that's what these conferences do. That is what these international conferences that we attend, that is what CME points are for. That is why we attend these conferences. So we learn from each other, we understand each other's perspective, we question, we debate, we ask questions, we try to kind of, accumulate what we can, we try to assimilate it, we try to put it in practice, we try to go back to the doctors and say, no, what this thing was said was wrong. I don't think this applies to my practice. So a lot of things that can happen. So it is not about somebody being wrong, it's about finding out another way, which can also be right.
So much. Now, as we wind down, Nurse Benjamin, you spoke a lot about Antigua Barbuda cancer support community and your passion, palliative care. What would you like to leave the public with tonight?
Okay, so I would like the general public to be aware that anyone who is going through any kind of terminal illness, you don't have to go through that alone. There is support, and not only for the patient, but there's support for the family. We tend to forget the family a lot because everybody focuses on the person that is sick, and the family or the caregivers most time, they are neglected, but they're hurting just as much as the patient, and they need support also. So we want everybody to know that there is help. You do not have to go through this fight alone. All you have to do is to reach out. In terms of palliative care, we want people to understand and to know that you can die in dignity. I mean, all of us are going to die at some day. And especially when you have a cancer diagnosis, when you get a cancer diagnosis, I mean, you might live for 20, 30 years after, but at least at the point of that diagnosis, you know that somewhere around the corner that might just come because of this disease. And as Dr. Nandan would have said, most of the patient comes to us at a terminal stage, at a late stage. So palliative care is about making those few months, or even if it's a year, peaceful. You know that you can die having your family around you. We talk about palliative care is about, as we would say locally, setting your house in order, putting things in place. How do I want to die in a hospital, or do I want to die at home? Do I want to go to hospice? And we want people to start to think about these things early. Don't wait until you're in the hospital and the doctor says there's nothing else we can do, and then the family is struggling around trying to figure, should we go to hospice? Should we do home care? What is available to us? So we want the general public to become knowledgeable as to what the options are and what is available for them as persons who are diagnosed with cancer and is at a terminal stage, because it's something that we can't get away from. It's going to happen someday. We have had persons, I've met persons in Breast Friends who, when I joined Breast Friends back in late 2017, early 2018, who were bright and sprightly and doing well. And then later on, cancer returned and they went downhill very, very quick. So we want to be able to put things in place and very early sit with your family members and talk about what you would want happen when that time comes, so that everybody can be comfortable and your wishes can be carried out. And Sharian, let me say, when you ask what would the doctors do to convince someone to take the chemo, they just ask me to speak to those patients. Those patients that are not wanting to take chemo, when Nurse Benjamin speak to them and Nurse Benjamin say, I had chemo, I had 8 cycles of chemo, and I had radiation, I had surgery, I had everything, and look at me, I'm not dead. And they said, well, okay, if you've been through it and you're here, I can do it too. So
you're a walking testimony.
Yes.
All right. Is there a difference between chemo and radiation, or is it the same thing?
No, there's a difference. Chemo is actually the drugs, the medication that it can be given through an IV drugs or through tablet. And the radiation is actually, radiation beam that actually goes to the specific area. So you have to go into a machine. You lie on something like the CT. Have you ever done a CT scan? Yeah, something like that. And the radiation beams, you don't see it, you don't actually feel anything. But after a while, you will see the effects. But when you're getting the radiation, you don't actually feel anything. At least for me, you don't feel anything.
But is this a specific type of radiation? Because from what I know, the little that I know about cancer, I think environmental factors such as radiation can lead to cancer. So is it a different type of radiation that is going through your body? I don't know if Dr. Nandan can assist.
Well, like I said, you've read the whole textbook today. So I'm really, I'm so impressed with the knowledge that you're presenting today. Well, the radiation that we're talking about for treatment is nothing but the strong X-rays. If you've ever done a chest X-ray in your life, it is the same X-rays that we use to treat the cancers. But yes, you're right that radiation is one of the reasons, not the treatment radiation that we're talking about, but yes, even they can cause cancers in later part of life because the DNA can break. So the whole idea is that these radiations can cause damage to DNA in the cell, and once they break, they're not able to kind of join properly again, which can be cancerous. So we are talking about UV radiation from the sunlight when the skin is exposed, so that it can cause skin cancer if it's been exposed for a very long time. So each radiation has got a different wavelength and they have a different frequency. The treatment radiation that we're talking about is in the wavelength of an X-ray. So this is basically the X-rays that we cannot see through the eyes, which have got a high dose of X-rays. So instead of giving you, to put it in a very simple term, instead of doing one chest X-ray, we are giving the dose equivalent to 1,000 chest X-rays to that area so that the cancer cell dies. We'll all have to look at the benefit versus risk ratio. Since the benefit is very much compared to the risk that we're taking, we go ahead and say we'll have to give the radiation to the patient to make sure for now that the cancer is completely cured or the cancer cells in that area have completely been killed. So radiation is much more local. It's like surgery. So we do it when we require to give it to a local area itself. Something like we do it for surgery. Chemotherapy is more like we give through the intravenous line, through the blood, so that wherever the cancer cells are in the body, we try to kill those cells through the therapeutic agent. Same thing like immunotherapy that we use as well.
So the new cells will come back. Like it will, after you would have killed those cells, your body will form new cells that are non-cancerous.
Exactly. So that is why we give breaks. That is why we do radiation for small doses every day, and we do it in breaks. We make sure that it's given every single day. That is done because the cancer cells do not have the time to regenerate themselves. Whereas the normal cells in the body, they are able to regenerate themselves at that time interval that we are giving. So we give the body the time to recuperate itself. But at the same time, we keep hitting the cancer cells again and again so that the cancer cells keep dying, whereas the normal cells are trying to regenerate themselves at that time interval. So that is the whole idea, that is the whole theory or the philosophy being by giving that radiation in a spread out area. Same thing with chemotherapy. Why do we do it every cycle? Why do we do it every 21 days or 14 days or every month? Because we want to give time for the normal cells to regenerate themselves, while the cancer cells actually do not get so much time. So by the time they're trying to regenerate again, we're going to hit them again hard. We're going to hit them again hard. So we give body time for the normal cells to recuperate itself. So that is the whole idea of trying to give these treatments in a very cyclic way.
This is some very, very insightful information, and I believe the general public needs to hear this. We definitely need to continue this public awareness because I think knowledge is power. And if persons can capture the diseases early through screening and through support groups like yours, Nurse Benjamin, I'm hoping that less persons will come to the oncology unit at stage 4 cancer. So, Dr. Nandan, any final remarks from you? What would you like the audience or the public to take away from tonight's message?
Well, the first thing, Sharian, I would be the happiest person if nobody comes to the oncology unit if cancer is eradicated all over the world. I've got other talents to survive on, trust me. So I will not even think even once if nobody has got cancer in the world. I wish we could come to a place wherein that can happen. But since the cancer actually incidence is increasing, I want to tell the public that it's a silent killer. Like I said, by 2030, it's going to be the largest killer in the world, overtaking cardiac diseases. To give you a perspective, I do not want to kind of demean or put down anything which is happening with COVID. The number of COVID deaths we have seen around the world is about 3.5 million as of today. We are talking about 9 or 10 million deaths that have already happened in 2020 due to cancer. 3 times that death. How many of us knew about it? That's the question. How many of us knew that cancer is killing so many people every year? And that's the sad part, because the awareness is still not there in low income, middle income, developing nations, which needs to be done at a rapid pace. We do not have enough cancer centers around the world to take the burden of these cancer patients. We do not have support groups. We do not have palliative groups around the world. And this is not just in one country. I'm talking about in countries like even US, they are still struggling. They are saying that they need more cancer centers. They need to have more, doctors, nurses, support care groups trained in trying to take care of these patients who can survive cancer, follow-ups and all that. So the burden is going to be huge, unimaginable by 2030. So I want the public to realize it's so important to kind of make yourself aware of cancer, but be bold. We have people like Sister Benjamin, who's amazing, full of energy. You call her anytime and you just say cancer and she can have a conversation with you. She'll never say no. If you say it is for the sake of cancer, it is something that she needs to do for oncology, she'll never ever say no. She's 24 hours available on the phone, as she rightly said. Anytime you call her and say, please help this patient up, she's willing to do. So I think we should be able to tap into these, the people like Sister Benjamin, who are selfless, who are willing to give everything that they have, every energy that they have, back to the society, to say they're willing to kind of go ahead. We need to encourage, we need to kind of tap into their resources, call them, ask them questions, get educated, get that awareness, support them as well. So please support Sister Benjamin's cause. It's very, 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 very important and very vital, not just for the country, but also for the region. Like I said, one of the unique kinds of support groups that has been started in the Eastern Caribbean. So people who are listening, this is your opportunity to get in now, to hold hands with Sister Benjamin, because history is being made. History is being made as far as palliative care and oncology is concerned in the Eastern Caribbean. So jump on the ship early so that you'll be recognized as well. Thank you so much.
I love your passion, Dr. Nandan, and we here at the Apex of Training and Development, we are truly honored to partner with Sister Benjamin and Community Charitable Ministry in order to bring public awareness. I think this is such needed information, and I think the more persons become aware, the idea is to have less cancer patients in the oncology unit, less stress, and probably we have to find a new career or a new specialty. Well, it was such a wonderful session. I absolutely enjoyed it. It was a pleasure having you. And I just want to mention that we have persons from different parts of the region that usually view our program. So you're not only sensitizing the Antiguan public, but we are reaching the region, and that is very important. And again, Nurse Benjamin, congratulations to you on making history in the Caribbean. And as we wind down to leading towards Cancer Survivors Day, I'm sure many of the cancer survivors are looking forward to that day, the church service in the morning and the different activities where different gifts will be given out to the cancer survivors. And I just want to encourage the public to support Sister Benjamin and this cause. At the end of the day, just lending your support, just encouraging them through words, just being there. It doesn't even have to be financial support if you can't afford it. So Sister Benjamin, could you please give the public your contact information again before we conclude this evening's session? And we definitely will have to bring back yourself and Dr. Nandan for a part 2 to continue the discussion on palliative care, because I think it is a much needed discussion that we need to continue. And I didn't know anything about palliative care until today. So I believe the public would really benefit from the wealth of knowledge that both of you have to provide on this very important subject area. Nurse Benjamin?
Yes, so once again, I can be reached at 722-1019. And I will add in another number just in case, 770-2954, 770-2954, or I can be reached at Mount St. John's Medical Center, the Oncology Department.
Thank you so much. It has been such a pleasure speaking with you, Nurse Benjamin. You're doing such a phenomenal job. Keep up the good work, and whatever way the Apex of Training and Development can assist you, we'll be more than happy to do so. And Dr. Nandan Shanbhag, it was a pleasure having you on our show this evening. You were full of life, your energy. It was just so good. Thank you so much for all the information you shared this evening. Our cancer awareness program ends next week with Miss Dr. Darren Ephraim, a gynecologist at the Mount St. John Medical Center, and cancer survivor Anya Joseph. So the final episode for this special edition will be next week, Thursday at 8 p.m. You don't want to miss it. Tell a friend, tell a coworker, tell a family member that the Apex of Training and Development show has partnered with Community Charitable Ministry, Antigua Barbuda Cancer Support Community, and the Mount St. John Medical Center to host a series of cancer awareness programs. And we will be concluding next week, Thursday. We look forward to having all of you. Once again, thank you so much for being a part of this evening's session. And thank you again, Dr. Nandan and Nurse Benjamin. Keep up the phenomenal job that you guys are doing. And I pray to God that you get less patients, even if we have to have a show every month, so that persons can be more aware, they can get their screening early. Less burden on the oncology unit. That is the aim, and that is the prayer. So just continue to do the great work that you're doing. Thanks to Ajane Seeley and Pascale Kentish, our social media coordinators, for always supporting and doing a phenomenal job, ladies. Keep up the great job that you're doing. They're both students at the University of the West Indies, and I'm just so impressed with the work that they've been doing, the support that they've lended to the Apex of Training and Development show. Ladies, I wish you guys the best. And of course, how could I forget Miss Francine James, the head of Community Charitable Ministries. And Miss James, continue to do the excellent job that you're doing. And to the listening and viewing public, remember to support these ministries, these charities, these groups. They need your financial support, and they also need your emotional support. So reach out to Nurse Benjamin, and she will guide you as to how you can go about assisting. And you don't have to be in Antigua to assist. If you're tuning in via the region, whether you're in Anguilla, Turks and Caicos, Grenada, Dominica, wherever you are, reach out to us. You can send us a message on the Apex of Training and Development show, and we'll be more than happy to share the information with Francine James and Nurse Benjamin. And again, once again, thank you for tuning in. It was a pleasure having both of you, and see you guys next week, Thursday, same time, same place. Have a good evening. God bless.
And God bless. God bless.
Thank you so much. God bless. Thank you.
You're welcome.